Okay, good morning, everyone. It is my delight to introduce our Grand Round speaker this morning, Dr. Pete Kliewer, graduate of Oregon State University. He went to med school in Washington University in St. Louis, and then completed his internal medicine residency here at University of Washington. After graduation, he has actually worked through many clinics throughout the WAMI region, including being a wilderness instructor at the Knowles Institute. And now, fortunately, he settled down at the VA Puget Sound, where he not only serves on our Code Blue Emergency Department and Emergency Management Committees, but also is a regular attending on wards and a teacher of both medical students and residents. I'm very excited he's here this morning, so please join me in welcoming him.
Thanks, Miller. Can everybody hear me? Okay. For that great introduction. And thanks to the School of Medicine for allowing me this opportunity to kind of express my thoughts and feelings about a subject kind of dear to my heart. It's good to be back at the mothership. I haven't been here in a while, and it's good to be back home again. So why do I feel that patients' experiences and patients' stories and our experiences as patients are so important? I think as I get older and my own personal medical record gets thicker and thicker, and I've had many opportunities to be caretaker for my family, I realize how much those experiences affect how I deal with patients and how I teach. I think our medical education community is really good at teaching pathophysiology and science, and it's amazing what we have to learn these days. But I think teaching life experiences as human beings is something we're not as good at. I think those experiences as patients, physicians and providers as patients, help us bridge that gap that I think has been created somewhat and widened in recent years between patients and providers. The experience of providers as patients is not a new one, and it's been documented many times in the past, and it's not necessarily an uncommon one. Dr. Shamroth listed gripes he had, and he actually listed them as gripes, back in 1976 when he was being treated in South Africa for endocarditis when he was pretty severely sick. And you could see that probably some things haven't changed and we're still working on. More recently, Dr. Oddish, in just one of the issues this month of New England Journal, expressed her opinions and perspective on being a critically ill patient and what she saw from that experience. I would take her thoughts one step further. Not only do we need to recognize our failures, learn from our failures, but I think we need to learn how to teach those and what we've learned about those failures to all those we're teaching, our young providers. Now, I'm in just awe of the people I teach, students and residents. It's amazing what they know. It humbles me, and I'm constantly find out what I don't know. And I think that's only become more prevalent because there's they don't have necessarily by definition the experience of life. Some of them do, but most of them don't. And I think with all they have to know, all the growing amount of knowledge, information, technology, and just what I would call the business of medicine, which has really become a prominent part of medicine, it's much harder for them. I remember, I haven't experienced dementia yet, although some would argue that. But I do remember being an intern and being really tired at night, wandering around the ICU and seeing a patient that was intubated and had Foley in, feeding tube, sedated, and I thought, boy, that looks peaceful. It must be so nice to just sleep and not even have to eat for yourself. My experience has taught me something different since then. We laugh at this cartoon, I think, but I have been this patient, and I most certainly have been this doctor. I think when we ignore patients' experiences and how patients see us in the provider system, we risk widening that gulf that exists between us. And I think the patient-provider experience has become more adversarial in recent years. So what is my experience with the healthcare system, at least the one that's probably most defined how I think about things now, and when did it start? In March of 2000, I had been in a remote village called Holden Village. I was a volunteer medical provider for them for a year at that time. Holden Village is it's about right here on this map, is a retreat center. It was formerly one of the largest copper mines in the world in the early 1900s through the 1960s, when it closed because of the price of copper dropping out. At that time, the whole village was sold to the Lutheran Church for $1. They turned it into a retreat center where teachers from all over the world come in the summer mainly, but also in the winter, to teach various subjects. It's staffed by about 100 to 150 year-long volunteers, and it was my job to take care of them. To get to Holden, you have to go to Chelan, and then you take a boat up the lake. This is down lake, and then as you go up lake, it becomes much more mountainous. And you wind up at a place called Lucerne, which is just a group of little cabins where there's a boat club there. At that point, Holden will send down either a snowcat in the winter or a bus in the summer and take you the 13 miles up the road to Holden Village. Most of my story will take place down in this area, which is Copper Peak. When you get to Holden Village, it's a group of large buildings. It used to be the dormitories for the miners. That's where guests stay now, and the chalets, which were the administrators' housing during the mining days, and staff lives there now. They have all these little tailings pile. The mine itself is about right here and is all through the mountain right here. This is Copper Peak, where most of my story will take place. Buckskin, and this is Copper Basin, where they get their water, and they have a penstock there that diverts the water down through their own hydroelectric plant. So during that year, I'd done a lot of climbing. I climbed most of the peaks around Holden Village. This is Holden Village down here, down below. This is the top of Buckskin. And you can see that this was late in the first spring I was there. You can see that there's lots of avalanche chutes. The village itself was planned by Swiss engineers to be out of the avalanche area. The only peak I hadn't climbed at that point was Copper Peak. So I was anxious to climb that. I was going to be leaving the village. So it was the last one I wanted to climb. This is the east face of Copper Peak, and the top is right here. My medical adventure started at March 31st at 4 a.m. It had been a clear, cold day, and the snow was nice and firm, and we were able to make good progress. I took one other villager I climbed with before, Jeff, up with me, and we made our way up into the basin, and then traversed across the face, and then we went up the face, so we traversed across here, and you can see that there's plenty of opportunity for avalanche through here. And then finally, this is obviously a picture that was taken in the fall. At the time I would have done it, would have been covered in snow, but it's easier to see some of the detail here. We came up to this side of the face and climbed up the chute, deciding that it was taking us quite a while to get up the chute, and that was probably not the best place to be. We decided to go up on the rib and continue up until about 11 o'clock, when we were about right here at our high point, which was about 7,200, 7,400 feet. At that point, it's the east face, so it was getting really hot and warm. Snow was getting slushy. At that point, we realized that this was going to be the first hot day of the year. It was going to be a day where avalanche danger was high, and it was bagel day in the village, and we wanted to get back. So we decided to start coming down, and we started glissading down here, which is a mountain term for sliding down on your butt down the snow. Stopped here for a little food just before we decided what we were going to do and how we were going to go down. This could have been my last meal, which, by the way, would have been Girl Scout Thin Mints. I still have a fondness for them. And at that point, we decided we wanted to get back a little faster, so probably poor judgment. We decided we'd try and slide down this chute. We felt that at that time that we were pretty protected from avalanche because of this bluff right here. So we got down to about right here, what we didn't realize is that that bluff didn't protect us from avalanche. What it did was keep us from recognizing that an avalanche was coming. And it was a hot day, as I said. We did not set the avalanche off, but a cornice, which is an overhanging layer of snow at the top of this ridge, broke off and started an avalanche that came down around here. And the last thing I remember for 2 weeks, because I don't remember what happened during that 2 weeks afterwards, was the sound of the avalanche. We had planned escape routes, but as my partner told me later, we didn't have time. We had like one step and then we were engulfed. This is what the conditions were like. This is taken just before the avalanche. I'm just sliding down there. That's not the avalanche itself, obviously, but this was just before. And it took us down from about right here, down 800 feet to about right here, and deposited us on, took us over this cliff, which was about 80 feet. I took this later when I climbed it later in the year, and then deposited us right about here. It could have taken us all the way down the mountain, which would have been, we were about right here. It could have taken us down to this huge avalanche field down in the basin itself, so I was fortunate in that respect. You can see that this is pretty much the kind of avalanche, this debris that I was caught up in. It's that time of year, it's what we call a wet avalanche, so it's big, heavy blocks of snow and ice that traumatize you. You know, people can die mainly two ways in an avalanche. One is to be traumatized, hit against trees, boulders, big slabs, or the powder avalanches that people hear about more, where they suffocate you, they bury you. Jeff, my partner, remembers the light dart, and going over the cliff. He dislocated his shoulder when he went over. When he came to, he called for me but couldn't hear me. He was able to follow my debris trail, basically of my poles, my gloves, water bottles, and finally found me down, buried up into my chest in snow, and somehow was able to dig me out. Snow, when it settles like that, becomes just rock hard and concrete. But it shows you what adrenaline can do to somebody when they're in that sort of a circumstance, much as we are when we do codes. It also is a point that you don't think clearly when you're like that. He dug me out, fortunately put my head up. At that point, it was pretty clear that I'd done something to my neck. My neck was already very swollen, probably the size of my head. There was really no definition there, he said. Very bruised. I had a number of lacerations I was bleeding from. Put me up. Even though he had the straps that he could have just flipped off, he took out his knife, cut them right by the buckle, and pulled my pack off. We didn't think of any of the things that I had in my pack, because in that state where you really need to slow down and think about what you're doing, we didn't. And I didn't think about that I had a radio in my pack, that I had a splint, which could have been formed to my neck. I didn't think about a shelter that I had in my pack, extra clothing, any of that. He just came up to me, and I faintly remember this, asking me what he should do. And I said at that point that I was probably going to die, and that he should go down to the village and seek help for himself, which he did. He had a hard time getting down. It was very soft. The avalanches were still coming down that slope, but he made it to the village. And by the time he got to the village, he had told them that I was probably dead at that point. The village called the sheriff's department, which has their own helicopter, and the deputy sheriff, whose name is Pete Peterson, was their helicopter pilot. He picked up the local paramedic named Sean Ballard. If any of you have been in Wenatchee, he's the Ballard and Ballard ambulance. He doesn't have a lot of mountain experience, but they managed to both go up, and in the helicopter. About that time, I was able to get the radio out of my pack and let them know I was still alive. And using that radio, I was able to kind of guide them into where I was on the slope. So that was about right here. This looks it's a lot steeper than it really is. It's about 30 to 40 degrees there, so about like that. It's not a place a helicopter can land, but he was able to kind of tow in the helicopter with the skids and form a little grip there. He told me that the blades were just about hitting the snow slope. So he was really risking his life. And Sean, who rolled out of the helicopter, was able to get out of the helicopter and climb up the slope to me And at that point, since he couldn't land or lift me, he had no way of lifting me off the snow, no lift capacity in that helicopter. He just took off and circled while Sean came up to take care of me. Sean also risked his life a great deal for me. Avalanches were still coming down. He said at one point that we discussed what would happen if another avalanche came, and he said, well, I'm getting on you and you're my toboggan. And I guess we were in pretty good mood. I don't know why. But in any case, we had to make that age-old decision of having two critically ill medical problems and deciding which one's more critical. At that point, it was getting much darker, colder. It was clear out and cold. And I was becoming hypothermic, and it was pretty apparent at that point. It was also apparent that I'd probably broken my neck. And we had to decide how. I'd had most of my clothing had been ripped off. I had my rain pants had been ripped off. My coat was ripped. So I was just laying out there in the snow at that point. He said that we talked it over and we decided that the risk was greater for the hypothermia. And so he was able to get an extraction device on me where it covered my neck and my torso, and was able to pull me up and put me in a sleeping bag on a pad to help me with my hypothermia. And fortunately, nothing else happened to my neck at that point. It was pretty apparent at that point that they couldn't get me off the mountain. We had teams coming from Holden, the same response teams that I had trained, and they were coming up, but it was going to be quite a while before they got there, and they didn't know if they could get me out on the ground. So at that point, they had to call the Fairchild Air Force Base that has rescue helicopters there, the Hueys, that could fly out, and they have a lift cable that they could bring me up on. And they have parajumpers. This is Dan, who is the parajumper for the Air Force, and this is Matt Lyons, who's the helicopter pilot. And they came in. They had pretty strict orders that they were not to fly after dark, which they broke, and decided to come up the valley to get me. They were able to send down the parajumper, Dan, who stabilized me in a Stokes litter and made sure everything was okay, and then lift me out using the lift. Matt and his co-pilot had to use their night vision to hover at 80 feet, which is very hard, especially at that altitude and those conditions. The night vision only gives you, cuts out your peripheral vision, and so one of them had to wear the night vision and the other one didn't, and together the co-pilot and he were able to manage a hover. And at that point, they took me off the mountain and took me into Wenatchee, which was the nearest hospital. Fortunately, at that hospital, I think initially the idea was that they were going to stabilize me, move me to Harborview. But at that point, there was a neurosurgeon there, the only neurosurgeon, Dr. Higgins, in that area, who happened to be a former attending at Johns Hopkins in neurosurgery, and felt that he could manage me there at Wenatchee without other serious injuries to my abdomen or elsewhere. So on my admit on March 31st, 2000, these are kind of the more major things that I had going on. Obviously fractured ribs, multiple fractured ribs. The most major thing obviously was that I had a C1, C2 fracture. C1 was a hairline fracture. C2 was just total burst fracture. It burst outward. Fortunately, none of the pieces had penetrated in my cord at that point. I don't know how I rolled around in an avalanche without being paralyzed or dead, but somehow I did. I think that probably what happened is I had my helmet on and I came down and had just pure compression on C2 and it just burst. And then I developed a large retropharyngeal hematoma. And so my hospital course, I was admitted to the ICU where I was for almost a month. They fused C1, C2 with a bone graft and a plate. Because of this large retropharyngeal hematoma, my swallowing mechanism didn't work. I didn't protect my airway, and also was just having trouble with the airway being compressed, and so they had to intubate me with a number 6 tube, and so it was fairly uncomfortable, so they sedated me for most of that 2 weeks with fentanyl and midazolam. During that time, while I was on the ventilator, I developed a Pseudomonas pneumonia, was treated with ceftazidime. Eventually, since they felt that it was going to be months before I was able to protect my airway, they gave me a tracheostomy. And eventually, since I couldn't eat for myself, they placed a PEG tube. I was eventually, in the last couple of days, transferred to the floor and then eventually discharged to my family's home in Oregon. And my post-op course. I got some rehab in the hospital, but it took several months of rehab at home in Corvallis, Oregon. For that, I was on 2 feedings during that whole time, which is very difficult with a mother who cooks excellent food. And I had to smell that every day. And she'd come out every day while she was cooking saying, "I'm so sorry, I'm so sorry." Eventually, I had the halo brace. I was in a halo brace, which is a brace, as many of you know, is actually screwed into your skull. I've still got those scars too. Still have the halo brace to remind me of my errors. And eventually, when that came off, I had a fairly good swallow. My peg was removed, and my tracheostomy was eventually removed. I had eventually turned to work in August of 2000, so about 4 months later. So what have I learned from all this? What kind of lessons can I pass on to people? And I don't know how good a way it will be, but what lessons can I try and attempt to pass on to you about what it's like to be a patient? First of all, it's what I call the fog of admission. When you get admitted to the hospital, it's an incredibly disorienting experience. I don't remember being admitted to the hospital because I don't remember those 2 weeks, but I most certainly remember waking up 2 weeks when they lightened up my sedation and going, where am I? What is going on? How am I in this state? It's an incredibly disorienting experience. The first thing I'll tell you is, and I think I try and catch myself, but I'm one of the worst people for this too, is you have to watch what you say around people. Dr. Oddish, in her description in New England Journal, when she was critically ill, remembers them saying, she's trying to die on us. And she was just horrified by that. Even though she's a physician and kind of was in that position, she realized that just sent horror through her. And I think even, our terminology that we use and the language that we have developed, we are kind of desensitized to that. And people who aren't desensitized to that, it comes off in a very difficult way and sets them into a very bad mental status at that point. So we have to be careful when they're conscious, obviously. Even when you're unconscious, you hear things. Things are incorporated into your dreams. I remember my sedation dreams when I was unconscious very well. They're vivid to me still to this day. That's how I know they were from that time. I don't remember my regular dreams at all, even right after I wake up. But those I absolutely remember, and I know I incorporated what people were saying around me. People who visited me were incorporated into those dreams, what people said. I remember, and a lot of this I kind of put together afterwards, but they must have said that they were out of morphine on the floor and they had to get more morphine. And I remember one dream where I was running around in pain throughout the desert looking for morphine. And it's a distressing dream. And, it was just a simple thing that they said to each other, but yet I incorporated that, and I'm sure that created anxiety within my physiology. So it's very important to remember that. I also remember a time somebody must have said they were going to get a Coke, and I remember I was dreaming that there was Coke bottles open all around me, but I couldn't drink them. And again, it causes anxiety in your physiology when that happens. I've been there at night when you're called for the 5th time to some agitated patient in the ICU, and you have to order restraints, and you get this kind of antagonistic feeling sometimes about that. But I've also been on the other side of that. I've been that person who's been agitated in their dreams. And, when you're sedated, unfortunately, a lot of what we think is self-preservation. You're thinking everybody's out to get you. It's a very paranoid state that you're in that unconscious state. And I think we have to remember that that's not necessarily them that's going on. There's a different person in there that's being affected by medication and situation. And, for instance, I hope there's no respiratory therapists in here. I apologize if I offend any respiratory therapists, but they seem to be my arch enemies in my dreams. And I'm sure one of those things was because I had a dream that they were putting a glass rod down my throat and shattering it. And I think that was probably deep suction. And so those kind of things affect how you see people. And, it carried over into some of my other dreams. I thought that the respiratory therapists were urinating in my IV bag. I'm sure that was the multivitamins, but in my state, that's how I saw things. So just understand that it's a different person in there, and try and understand that. You can't relate necessarily if you haven't had that experience or understand what's going on in their minds because they're sedated, but just try to be compassionate and patient. And this carries over to some of the other ways we treat patients. For instance, I think one of the things that I've been guilty of, and I think we do sometimes, is that we blame the patient or shame the patient. I don't think it does much good to tell them how they got to that state. They already know that in a lot of ways. I mean, I think it's part of what you do when you work them up. But to constantly be telling them that it's their own fault that they're there, I don't think it would have done me any good to have somebody say my poor judgment caused my injuries and therefore tough luck. I think it comes off that way sometimes, and we have to be very careful how we say those things. When you're admitted to the hospital, and especially serious or critically ill patients, you are a different person suddenly, and we have to take that into account. You go from being suddenly healthy, in my case, on the mountain climbing, to 2 weeks later, totally debilitated, totally dependent, and that's a tough thing to handle. And for some people, even though I was told mine would get better, but for some people, that's a permanent change, and you have to help them with that. That's a very difficult thing for people to take. I can't imagine. I spent a lot of time thinking about what if my spinal cord injury was permanent? How would I feel with that? I didn't believe people when they said it wasn't, for one thing. You totally have lost the control. When I woke up in the hospital, I couldn't eat. I couldn't breathe on my own for a while because I was still on the ventilator. I couldn't pee. I had to have somebody help me with I couldn't even sit in a chair. I could push the little button on the remote control, thank God, but I couldn't do anything else. And that's a hard place to be. You lose all your dignity when you're in the hospital. My siblings love to remind me that I laid there naked in that bed for a long time before they came. Often when they came in, that's the state I was in. I think we have to really be aware of patients' dignity. I think we're doing a lot better job of that, closing the door when we examine people or making sure that they're not visible to other people. I think that's really important. You lose your ability to plan your future because so much is uncertain. And that uncertainty, when you're laying there, you have that uncertainty in your mind at all times. I was certain I was never going to get my swallow back. And I don't know why I focused on that of all the things, but it just makes it very hard. You plan a different future than you may necessarily face. And loss of time. When you're sedated, there's no recognition of record of that time period. That 2 weeks still kind of creeps me out. I don't remember it at all. I was suddenly healthy and then I was in the hospital, and it still makes me think a lot about how suddenly things can change. I really advise my patients or my families of patients who are in this state to keep a diary of some sort so that they can help the patient understand what happened to them during that time and kind of fill in some of the blanks. I think fear is something we can all relate to. It's a much different kind of thing when you're on the other end of that. I think procedures are a big, obvious source of fear for people. I knew what was coming. I knew what the procedures were, and I still feared them a great deal. It creates a great deal of anxiety. I don't think we do quite as good a job with consents as we should do. That's a real time when we can sit down and spend time with a patient, answering their questions, talking to them in terms they can understand, explaining what will happen in realistic terms, being honest with them. I think we need to spend more time doing that. I know it's not always possible, but I think it's an absolute necessity to do that. I think studies show also that your outcomes are better when you lower patient anxiety. The outcomes are better for the procedure and outcomes are better for them. Fear of pain, obviously. I think part of this is just having conversations with patients and talking to them about what their expectations of how much pain, what their alternatives are, what kind of medicines are available to them. And I think you have to recognize when patients are in pain all the time, scheduling meds is really important. I can't tell you how many times I waited for somebody, it seemed like hours and it was probably just minutes, waiting for some relief from a PRN med. I think you also need to talk to them about their side effects and what to expect and what we can do about them. I don't think dysphoria and nausea are good trade-offs for getting pain relief. I think we need to treat those two and think ahead. Fear of the unknown. Again, you just don't know what's going to happen to you or what the future holds. I think the solution to this is to develop trust with the patient. As I said, I didn't believe my physicians lots of the time when they told me I was going to get better or something wasn't going to happen. because I had so many different doctors. My neurosurgeon was very good about his end of things, but there was a lot of doctors who just didn't spend time with me, and I would never trust a doctor who just ran in, looked at me in the morning, and ran out. You need to spend a little bit of time with a patient and develop trust with them, and then the patient will believe them when they tell them something. Fear of anesthesia is much greater than I would have expected. The American Society of Anesthesia estimates that 1 in 4 patients postpones their surgery or procedure because of their fear of anesthesia itself. Another study showed that 54% of patients fear that they will never wake up if they're put in anesthetized. 19%, and this is my fear, fear that they'll wake up during the procedure. And then 38% really fear waking up in severe pain that can't be controlled. So we need to make sure that not only we spend time consenting patients, but the anesthesiologist is there to answer their questions and give them realistic expectations of what's coming. And you name it, you're going to fear it. Everything that came through that door, because I had all that time to think about it, was a threat to me. And so you have to kind of understand when you come in that door, you need to establish rapport right away because you're seen as a threat in many cases. I think you're just creating a good environment in the hospital is really important. I'm a big dog person. This was great. This was a great day for me to come out and have a friend bring her dogs for me to see, and then obviously family too. Staff is critically important. You're totally dependent on them. And I knew who was good, who was bad, nursing staff and ancillary staff, and I dreaded certain nurses coming on at night or certain respiratory therapists. You have to be an advocate for your patient. You have to believe them when they say that they're having problems. You're serving them. You need to be the go-between between the staff that might be causing the problem and the patient so that the patient knows you're advocating for them. Noise, we've all talked about this, but it's still a problem. One study showed that they measured the noise level in ICUs. It was 67 decibels on their study. That's the sound of a lawnmower running at 10 feet. That's a lot of noise. Even on the floor, it was 42 decibels. The World Health Organization recommends no louder than 30 decibels for good rest and healing. And before we say, oh, that's we can't really control that, that's alarms, that's machinery, they found that it was really staff conversations and people talking that was the greatest part of the noise, and we can control that. Temperature obviously is important. I'm obviously a cold person. Maybe that's why I survived that. I needed fans on me all the time. It made an incredible difference to me, but just asking the patient about that. Fresh air is important if you can do it in this world of sealed buildings, often hard, but if it's ever possible to get the patient outside, it makes a big difference. Dr. Shamroth, who I mentioned earlier in South Africa with his endocarditis, he was being treated with gentamicin at that time, and he said the thing he looked most forward to was when he had to go out to the trailer where they did audiology exams on him for his hearing, and he could get outside. It made a huge difference in his outlook. Lights and day, night cycles, again, very important. I think we know that. We do a pretty good job of trying to deal with that, but just be aware of your light use and how, shining lights in people's eyes and things can make a big difference. And then just helping the patient connect with the outside world, as I did in that picture, just having the little things in their life, trying to make it's their home for a while and trying to make it more like their own home is a really good thing. So supporting the support is really important. I don't know how people do it that don't have family and friends and people to support them, and I'll talk about that a little bit later, but it was incredibly important to me, not just for my hospital, of course, but knowing that they'd be there for me for the long term. So when you come into a room and the family's there, introduce yourself and do it multiple times, because I'm one of those people who never remembers names, and I try and introduce myself every time I see a patient again until they say, I'm tired of hearing that, and then I can stop. But a number of patients came in. I have a very medical family. My dad's a physician, my mom's a nurse, my sister's a nurse, and they were all there. And often the doctors wouldn't even introduce themselves to you. And my sister, who's just a mama bear, would just tear them apart about it. And I think it is important, that's a great advocate, but it is important to introduce yourself and let them know. And also recognize that not all family and friends and visitors are welcome. You're a captive audience when you're a patient, And I don't know how many times that somebody was coming by, chaplain that I didn't like or something like that, that I would just pretend I was asleep because I just didn't want to deal with that. You're trapped. So ask the patient. Find out who they really want to see and don't see. Find out where the support is staying and how they're going to eat and how they're going to survive. Down at VA, we have a great thing, Fisher House, where families can stay. They had the equivalent of that for my family in Wenatchee. It was incredible help for them. You can imagine what it's like for some guy to come in from Ritzville and come into the Seattle VA, and his family's from rural Washington, and try and find a place in Seattle to stay that they can afford, or where they go to eat, or any of that. Talk to them. It makes a big difference, and do what you can. Especially with critically ill patients, I think it's really important that we try and support families, at least one family member to stay in the room. I remember a lot of nights I was having flashbacks where I really thought I was being buried again in the dark. And the difference was that somebody I knew was there who brought me out of that. Assist the patient in communicating with the family, make sure they know how to use the phone, know how to contact their family, keep them up to date. I know that's a hard thing to do sometimes, but at least make an effort at keeping the family up to date. Address their financial questions. This is a huge issue. Even at the VA, we have patients constantly wondering, is this something I'm going to get paid for? Is my family going to go broke? I'm afraid the system in the future is not going to get better, and there's going to be a lot more people that are going to need help with their financial issues. And then when there's no family or friends, I think you need to be the advocate for them and the support. I remember when I was an intern, and I was signed out a patient when I was on call. He was in his early 20s. He was an HIV patient, and this was in the 1980s. So he was dying of a pulmonary infection, several, and he was signed out to me that he would probably die that night. And so when it became apparent in the middle of the night that he was indeed coming to the end of his life, I called his parents. They were out of state, and they promptly told me in a very loud way that they didn't want to have anything to do with him, they didn't know him anymore, and hung up. And after I got over the shock of somebody being so hateful, I looked for an emergency contact, and there was a woman's name listed. And I called her up, and I woke her up when I called, and apparently at first she said, I don't know who that is. And so I described him to her, and she said, oh, that's the new guy at work. He had not had any friends or family or anybody to kind of get an emergency contact from. So he listed this woman that was friendly to him at work on his first day of work as his emergency contact. So I described the situation to her, and amazingly, just a great person came in, sat with him, held his hand until he died in the morning. That is an advocate. She didn't know this guy. We don't necessarily know our patients very well, but you can be that kind of advocate for them when they have nobody else. Obviously, our job doesn't end when we leave the hospital. This is me coming to my family's home. This is the same paramedic, Sean Ballard, who got me off the mountain, and he took me the 7-hour drive down to Corvallis, Oregon from Wenatchee. He got insurance company to pay for it, amazingly. And so I think, even at the VA, we have to think about these things. What can the family really do for themselves? We can be the best doctors we can possibly be. We can get the amazing diagnosis, the just right treatment. But if the patient, we don't know that the patient can't pay for that medication, or they have to drive 100 miles to get it, or their spouse is stealing their medications, whatever that might be, all that diagnosis and amazing, brilliant doctorism doesn't mean a thing. Okay, so just keep it in mind that you have to follow through on your amazing abilities. You have to find out if they need extra services or home support. I needed a lot of this. I needed suctioning, all kinds of things that needed to be set up. And often we wind up just saying, oh, we'll do that after they get home. It doesn't work that way. You need to do it before they're discharged, because once they're discharged, as we all know, we just tend to let things slip and we don't follow up on things sometimes. I think some of us are very good at that, and I commend those people, but it's just too easy to not have that impetus to get that stuff going. Interestingly, I had suction, And my father, who's an oncologist, and his friend who's an intensivist couldn't figure out how to set it up, but my mom, the nurse, could do it. All right. Think as if you're being discharged. You know, try it sometime. Lay in bed at home and think about yourself as if you can't move, you can't feed yourself, you can't get to your medications. Think about how you would do those things. How would you get groceries in your house? How would you get in and out of the house? You know, how all this stuff that you just take for granted every day. Just think about that and walk through what that patient would have to go through. And the experience will last a long time afterwards. 1 in 4 patients, according to a Johns Hopkins study, will suffer PSD, major PSD after a critical stay in the ICU. So get them ready for that. Help them anticipate what they might be going through and what the options are at that point. So in summary, show respect. You know, I didn't think about it, but you know, we have the new parking garage at the VA, and every day when you walk in, there's only one word that's imprinted on a little concrete wall there, and that's respect. And I thought that's probably what we really do need to be reminded of constantly. We need to respect each other. Communicate with the patients and communicate in a way that they understand. You know, use their language, make sure that they're the center of the conversation, listen to what they're saying, and give them time to answer questions. Admit mistakes, be honest. I think I have all tried in recent years to do this. I think it's a really good thing. I can tell you that one misrepresentation of something or one lie to a patient, that's it. You know, you don't trust them for the rest of the time. You know, support the support, as I said. It's really important. Advocate for your patient. I can't emphasize this enough. Put yourself in their place as if they were having to deal with a bad staff member, or their pain was out of control, or they needed certain things. Don't take it personally when they're agitated. It's just the drugs and the situation talking. Help the patient arrange for the new you that they might be after their discharge. I was a totally different person when I went home to my family's house. You have to think about that. And if they have a permanent disability, you have to get them ready for thinking outside their old box and then the new box. And no matter how good the bagels are, they're not worth risking your life. So I did go back. This is the top of Copper Peak. We did make it to the top. I think it was about a year and a half later. This is Bonanza Peak in the background here. That's the highest non-volcanic peak in Washington. We've also been up that without incident, fortunately. And it was thanks to these guys. This is Pete Peterson. He's the deputy sheriff, now retired in Wenatchee. He flew the helicopter. This is Sean Ballard, the paramedic who risked his life on the mountain. And this is Matt Lyons, who was the helicopter pilot. He was getting an air medal for his rescue of me at that time. And because of them, I can now celebrate a new birthday on March 31st every year. And that's it. Thank you.
And I apologize. I don't know how the microphone works.
Great talk.
Thank you.
I'm interested in knowing how you gather information and act on the information regarding the behavior of specific professionals toward the patient.
You're talking about like in the hospital, if a certain...
Exactly. Your comment about respiratory therapists who broke the glass in your trachea, and et cetera.
Well, I think, first of all, use your support if you have that. I think, you know, going to your support, because you're not able to really go around the hospital, figure it out for yourself, obviously, when you're a patient very well. But most hospitals have patient advocates, and they can be a big help also. You know, for me, it was a little easier because I understand the whole mechanisms of personnel in a hospital. So I knew I could ask for the chief nurse, nurse manager, and directly have them talk to them. And obviously, my family knew that kind of structure too. But for somebody who doesn't have that, I would just say the best thing is to go to their supervisor at that point. And hopefully it's taken from there. Unfortunately, I'm not sure every hospital has a different ability and efficiency in doing that. Did I answer your question somewhat? Okay.
Thank you, Pete, so much for such a wonderful talk, and thank you for sharing your experience with us. You mentioned at the beginning of your talk that you thought it was important to try to think about how to teach trainees about a lot of these principles, everything that you said. In your time since the experience, like what kinds of ways have you thought about for how to teach these sorts of things effectively?
I think the best way to do it as attendings and teachers is to role model the behavior you want them to do. I'm still not great at that in a lot of ways. I still have a lot of the old habits and still get tired like everybody else, which is no excuse. But I really do try to go in, introduce myself over and over. I try to keep my voice down, which is not always easy. I try to find out what their family needs. I spend a lot of time with family if I can, and I'm hoping that role modeling some of that will help. I also, specific situations where I see them doing things that they don't even realize they're doing, I'll point out and try and make that a teachable moment. I haven't really come down to trying to figure out how to do it in a academic sort of way yet. I think it is more kind of a, kinetic kind of thing that you have to role model for people with some reflection.
Thanks so much. I've sort of struggled over the years trying to figure out, so you walk into a room and the patient is there, and then there's like two people who you don't know who they are, and it's like that slightly awkward way of figuring out, short of saying so who are you, of just the graceful phrase to use to sort of understand who the other people in the room are.
Yeah.
And so, any thoughts on that?
Yeah, that's a hard one. It is awkward because sometimes, I have actually talked to people who were there for the other patient in the room. So, I usually just introduce it by saying, I'm the physician that's taking care. This is our team. We're the team that's taking care of this patient, and use their name. And I would just say, do you have questions about his care, and how can I help you? And then inevitably they'll introduce themselves at that point. But just try and kind of include them with the patient there and kind of get the patient to talk to kind of as a group. I think that's one of the ways. But sometimes it's tough because some family members or support systems are automatically have had a bad incident with the healthcare system themselves or at that hospital, and they're automatically an adversarial role, and you really have to spend some time kind of trying to understand why, what their situation is and what's happening. And I think that helps you treat the patient too, because that support system person's there a lot more than you are. And so if you understand what they're telling the patient, that can help.
One of my colleagues said, if you find any place to sit down for even a minute, that makes a lot of difference. And I think that's a tactic that's wise to keep in mind. If you can just sit for a moment, it doesn't take much longer of the visit.
Yeah,
worth it.
I would agree with that. For one, I think that's really good from the standpoint of communication with patients being on their eye level. It's never a good thing to be standing over them, I think. I really admire one of our palliative care doctors who takes his own little camp chair around with him. And he sits down and actually talks to patients. That sends the message to the patient that you really want to be on their level, communicate with them one-on-one, and that you're not going to just run right back out of the room. You will be sitting there and listening to them. I know it's hard. It's hard on rounds. I mean, I'm there with you, but we have to try and do this better. I really do think the outcomes will be better. I think that's a very good point.
Pete, thank you so much. All the years I've been friends with you, I heard stories about this, bits and pieces, but I've never appreciated, what you went through as a patient. And teaching this to us, I think definitely is going to personally make me a better physician. And I have a question regarding how to deal with staff members. I don't want to pick on respiratory therapists, but nursing staff or any other staff members that may come in contact with the patient that you happen to notice might not be doing, what you consider to be a professional or, helping the situation, or maybe even slightly mistreating the patient. And I find it a challenge for me to have to address that kind of behavior when I know, there's so much demands being put on us every, minute of the day. And also, sometimes I feel like, who am I to sort of call on them and make a judgment on them? But what kind of advice, and how do you tell your residents, what advice do you have for our trainees to address that?
Yeah.
I mean, how can they address that?
Yeah, it's a tough one because you have to work with that staff all the time. But I think what you always have to keep in mind is that your job is totally focused on the patient. That's what you need to take care of, and his or her outcome is what you're worried about. I think this is another chance to role model behavior with that staff member. I think you can be professional. I think you can be non-antagonistic to them, but you can also take them aside yourself. I think this is a chance for one-on-one conversation with them. Explain what you've heard, listen to their side of the story, but also tell them that this is what the patient is perceiving, and that whether it's true or not, they need to be aware of it. And if it gets to the point where that staff member, and you've witnessed it, is obviously not performing professionally, then I do think you need to go to their supervisor at that point. And I think you have to do that. And I know that's hard, but you have to. We're not selling bread here. We're taking care of patients, and I think we really need to have them first in mind. Not that selling bread is bad.
It seems like a lot of what we can do to take better care of patients is focused on improving our communication, but also improving coordination of care, thinking about them as people when they leave the hospital. I'm wondering if there are systemic changes that you've seen through your career about the way we take care of people and who's on our healthcare teams, or things that you might be helpful for the future to help improve that coordination from in the hospital to people in their real life outside.
Yeah, that's a good question. Some of the changes have been good. Some of the changes have not been so good. I think electronic medical records could be a big help because the communication can happen at light speed to some extent when we actually look at it. But I think it still comes down to kind of humans being there. And I think having a team effort is good. I think when we try and involve nurses in the morning, because they're the ones who see the patients, hear the patients, deal with them all day, when we involve them in our rounds and our discussions, when we involve social workers, we have a team approach that covers the whole span of the patient's stay and after stay. I think that helps. I think we're still working on that. I think it's a real work in progress to get that team approach. So for instance, discharge planning, I think that's a good effort that can really help with that. I think we're looking towards that. The trouble is sometimes we get so involved in the process that the patient kind of gets lost in that. And I think we have to constantly keep ourselves in touch with who the patient is and what they really need at that moment.
Excuse me, thanks for a great talk.
Thank you.
In regards to your comments about role modeling, I have to say that I was always a better doctor when I had a student with me.
Yeah.
And I think people in academic medicine often have trainees with them. And we can see this as a great opportunity to be better ourselves. You know when you're doing it right, and it feels good. And let it carry over to your time with patients when you don't have a student with you. But it is a great opportunity to get better at it by role modeling it for students. It's good for us as well as for the student or the trainee.
Yeah, I think that's a really good point. I've spent most of my life not in academic medicine and community health care and homeless care, and I think that's very true. One of the really great things about coming back to teaching setting is that it does make me conform better to what I actually say. I actually practice what I say for them. And I think that's a very good point.
I was wondering what you thought about, it seems like a lot of the models that are coming for reimbursements are including patients' perception of their care and including them as a contributing factor of how reimbursement is going to be dictated. How best do you think that should be addressed? I guess from some of my experience, I see the extremes of patients, what we call often the frequent flyers, who have this expectation that it should be the Hilton, and they're calling out staff to be, where's my waitress and things like that. And when you, I guess, what are some thoughts on just that? I've even seen up to 25% of reimbursement being from patients' experiences.
Yeah. I'm not exactly a policy person, but I understand that, and that is a big concern. I think you're right. It goes both ways. I think, I've had patients where I feel like, the temptation's always there to give into what they want so that they will have a better image of you, and that may not be the best thing for them to do, obviously. I often tell my students that we're not here to make patients feel better, we're here to make them better. And I think we have to keep that in mind. And I think there's going to be some patients where you just can't do that. I think there's just a certain psychiatric issues or behavior issues that just make them very difficult to communicate with, and help them to understand what is best for them might not be necessarily what they want. But I think most situations can be helped by good communication. I think we do have to formulate our reimbursement very carefully on that. And I don't know. I wouldn't want to be in the position of having to pick how we do that, because I just don't know what goals we want to set for that. I'm sure it's all going to be solved in the next 4 years, right?
Thanks, B, for your wonderful talk.
Thank you.
How would you suggest us in encouraging patient and support to speak up if they worry about staff retaliation?
Mm-hmm.
I've heard that more than once.
Yeah, I think that's a good idea too, and that's part of just because they're there all the time, or less. Sometimes, I shouldn't say that, but they're often there more often to see what's going on. Great.
Thank you so much.
All right, thank you.